Hi, I'm Dr. Steve Elias, and welcome to the veinPODCAST. Respect the elders, embrace the new, and encourage the improbable and impractical without bias. Okay, so welcome everybody to the veinPODCAST. I'm Dr. Steve Elias. So today we're going to talk about some stuff that's relatively new in terms of technologies, and the theme of this podcast is really venous thrombosis, the changing paradigm. Are there things that are changing in terms of our thought process and also the technologies that are available? With us today is Makis Avgerinos from the University of Pittsburgh, and he just told me he'll be splitting his time over in Athens, Greece as well. He's a vascular surgeon. Tom Bernik I work with him actually. He's the chief of vascular over at Englewood Health in Englewood, New Jersey, a vascular surgeon, obviously. Mitch Silver from Ohio Health, who's an interventional cardiologist, but not your run-of-the-mill interventional cardiologist, as he says. He takes care of all of the arteries and blood vessels, veins as well, from the top of the head down to the tip of the toes. And John Moriarty, who is interventional radiologist at UCLA. So welcome, guys. As we said, the topic is acute venous thrombosis, the changing paradigm. So I want to ask you, start thinking about it, and then I'm going to pick one of you guys to answer first. Why has this become so popular? I mean, 10 years ago, this was like a relatively mundane topic, or even 5 years ago, that nobody was all that excited about. Why now at every single meeting and every single, virtual meeting as well, this is kind of a hot topic, the treatment of venous thrombosis. So, Mitch, let's start with you.
Great. Thanks, Steve. It's a good question. And, I think you're right. It's been an orphan disease for years, right? Undertreated, underrecognized. Everybody that had a swollen leg from an acute DVT was put on oral anticoagulation and kind of pat on the back. Good luck. Hope you do okay. And, I think in part, thanks to our industry partners, they've given us the technology and the tools to really treat patients with acute DVT in a way that's very safe and very efficacious. And, once you get into this space of venous disease, you realize the patients that get treated with oral anticoagulation, they sometimes don't do very well. And in fact, the story with iliofemoral DVT, about 50% of patients have post-thrombotic syndrome with just oral anticoagulation. And it's a huge quality of life hit. It just didn't get taught in medical school well. It didn't get taught in residency. It was an orphan disease, but it's really received a lot of attention. And I think it's great because it's very gratifying to treat.
Yeah, I mean, and Tom, you've been taking care of this stuff since the early 2000s. But again, it was not like, the sexy thing that people were talking about at meetings. Why do you think now, aside from what Mitch said, why do you think now we're all excited about this?
Yeah, this was, I first got interested in this back in 2002, 2003, and when AngioJet first came out, and I kind of embraced the technology. And that was always a big no-no. Conservative treatment, was basically the treatment of choice. I think it took a long time to get the word out that we're not damaging patients when we treat them, and that a lot of the treatments really are relatively safe, and technology, like Mitch said, has changed so tremendously. And, it's a prevalent disease. I mean, this isn't like aneurysms when you're trying to get into an aneurysm space. I mean, DVTs are quite common, multifactorial, and there's a lot of neat gadgetry that comes out, and that attracts a lot of different physicians, particularly now that it's all percutaneous. Many disciplines can get involved in this, and I think that's nice because that's multiple different types of expertise. You see it right here.
Yeah. So John, talk to me about during your training versus now in terms of the management of DVT. What devices did you have available to you, or technologies or techniques when you were training versus what's there now?
Yeah, thanks, Steve. And, I think I have a kind of an interesting path to this, because I not only have the difference between when I trained, over a decade ago to now, but also where I trained, and that I did some of my training in Europe versus some of my training here in the States. And so, what we had available off the shelf in Europe was pretty different and is pretty different now to what you have here. But I think, if you were to say kind of global sort of themes, in the kind of pre-2010 sort of era, you're really talking about lysis and balloons, with stenting to bail out the iliacs after that. And as Tom was saying, angiojet was one of the first devices, and then trellis came along after that. That was on the market till the kind of early 2010s. But now, if you look at what we have, you're talking about direct thrombectomy devices, aspiration thrombectomy, rheolytic thrombectomy, enhanced catheter-directed lysis, whether it's with ultrasound or with a basket technology. So it's a world apart. And then, like someone was saying, it's kind of the new sexy thing when it comes to interventional therapies.
So Makis, let me taking it off on what John just said about all the things we have available. Just because we have things available, does that mean we should change the way we think about managing DVT? Just because a procedure is easy, should we?
Well, that's an excellent question. And we shouldn't really get down that pathway just because we have so many fancy toys, we should be using them. But alongside with the industry coming up with these new devices, there is evidence building up. So there where we had the haziness 10 years ago, now we started having randomized trials complete, multiple series, multiple experienced people presenting their good outcomes. And on top of this, having the evolution of the devices, I think these two coming together, we better select our patients, we better select our techniques, we have better outcomes.
Yeah, and that. Now, Makis, I did not share with you my next question, but you set it up really nicely. So my next question was going to be to all of you was, we were all anticipating the results of the ATTRACT trial a couple of years ago. Did the ATTRACT trial tell us anything that we didn't already know, those of us taking care of acute, venous thrombosis? John?
I think it was one of the more interesting times to be in the room when something is delivered. I was there when Suresh Vedantam kind of released the results, and you heard everyone just go, "Oh God," And I think it was that the hope had been that this would be somehow change what everyone already knew, that we should not be treating every DVT that walks into the ER. But the hope had been that we would find real benefit to FemPop disease. So to kind of get back to your question, did it reinforce what we already thought? Yeah. It told us that, everyone with a popliteal DVT does not require an intervention. Did it, taper the edges on where we are intervening? I think it did as well. And so that, it's changed some practice probably for the better.
I mean, I hope so. I was there also, at that when he kind of presented everything, and it was, everyone was sitting on the edge of their seat. I agree with you. But I think the people who were doing everything right, so to speak, who were thoughtful, it just reinforced. But I'm hoping it changed the ideas of those people who were doing a lot of stuff, that maybe those of us here don't think was the right thing to do, to intervene on these people and stuff. Mm-hmm. Mitch, what are your thoughts about what the ATTRACT trial taught us, and as to take off on what John said, taught those people who maybe just DVT, I'm getting rid of the thrombus?
It's a great question. I have a different spin on it. To me, it was a negative trial, right? And it was a big deal. New England Journal of Medicine, 2017. And basically the conclusion is that venous intervention didn't work. And by the way, there was a trend towards more bleeding. But I think the big point is it was a very important study, but it's not the way in which we do venous intervention now. That study started in 2012. It took 5 years to enroll. And we've learned a lot from the ATTRACT finish to where we're at. And if you look at ATTRACT, they didn't use IVUS very much. It was mostly venography. Their lytic times, where the mean was like 20 hours. We rarely ever infuse somebody that long anymore. Venous stents weren't around, dedicated venous stents. The stent rate was only like 28%. So it was a great study, but I think it shouldn't have turned people off from it. But the big thing was the sweet spot were the iliofemoral patients. Tony Camarota showed that in that subgroup, if the Volulta was 10 or greater, there was a signal of benefit in the iliofemoral. So the thing we learned, and that's pretty much our practice, is the patients with the sicker leg, the iliofemoral DVT with high Volulta scores, stand the most to benefit. But now we fast forward to what we've got. We've got these wonderful thrombectomy devices. We use intravascular ultrasound. We've learned a lot about iliac vein compression. We have dedicated venous stents. I think we can do better than ATTRACT, and we will. I'm confident of it.
Yeah, I think so too. So Tom, when you were lysing these people back in the early 2000s and stuff, what was the thought process going around like, okay, we got rid of the thrombus. Do we need to do anything else? Was it a low amount of people that we said, look, we got to treat the underlying problem? Or what were most people, were you doing saying, hey, this guy's looks like a stenosis here. I got to put a stent in this person.
Yeah, interestingly, I wish, I was in private practice at that time, and I just didn't have the ability or the resources to publish my data back then. But early on in 2004, I had my own series that I did, which was arterial venous, and some AV access, SVC syndromes, everything. And, the data was really kind of very similar that you see across the board. And very early on, I actually came to my own conclusion, which was that, below the inguinal ligament and popliteal, it just doesn't work great. My theory was clean the clot, obviously, just like we do with AV access or anywhere else. Find the underlying problem, because there usually is an underlying problem, and treat it. I even went as far back then to lyse through the leg, wrap the leg, and put IVs in the foot, and try to drive, saline and TPA deep into the system. Yeah. It didn't quite work, So it reinforces really what we kind of thought we knew, and in fact, it is true now, unfortunately.
So Makis, let me ask you. I want you to talk about the two extremes, and then all of us are going to talk about the gray areas. Mm-hmm. So give me the best case scenario to consider some type of thrombus removal. And I don't want to use the word thrombolysis, because we're going to get into a little bit later on the non-thrombotic treatment and the non-thrombolytic treatment and the thrombolytic treatment of venous thrombosis. What to you, Makis? You get the call from the resident of the ER. What case are you salivating that you can't wait to get in there?
Well, that's an easy question. If you want the extreme, this is a phlegmasia case. The patient who has like the extremely swollen leg, extreme pain, and he starts having sensory loss. That's an easy call.
Okay, so now give me the opposite easy call, which is, what is the patient you absolutely would say, no way, I'm doing nothing,
Well, the old patient with femoral popliteal DVT, a patient more than 70 years old, more than 75 years old with femoral popliteal DVT, some swelling.
Okay, that guy you're doing just anticoagulation.
Right.
Okay, John, give me one gray patient. One patient where you're not quite sure, should I do it or shouldn't I do it? Give me a clinical scenario.
I would say the person who is super active, a runner, sportsman, whatever it is, and has some limitation based on their presentation, but they're in no way going to Makis's extreme of the phlegmasia. But they are limited, and it's getting in the way of their quality of life.
All right, so that's a gray area. You're not sure yes or no. All right, we're going to get back to those gray areas. So, Mitch, give me another gray area.
I agree with John. We see maybe 6 or 10 young athletic patients a year that just have a femoral popliteal DVT, and they usually do well with anticoagulation, but maybe 30% don't. And to them, being active, and maybe I had a college volleyball player several months ago, she did not want any risk of post-thrombotic syndrome. And they're young, and their risk of thrombectomy and adjunctive lysis is so low. In that population, I think maybe it's okay to be more aggressive. In the younger athlete, that their leg function's really important to them.
All right, so now you walked yourself into the swamp.
Sure.
Okay, you're in the quicksand now. Okay, Mitch? Here you go. You, Mitch, who before we started this recording of this podcast, you said you really like biking. You enjoy it, and you do it, not just for la-di-da, but you do it for exercise. Mitch, if you had a femoral popliteal DVT, what would you suggest? You're an active guy. I don't care about your age.
Absolutely. It's a great question. I think I'd take a hard look at the duplex, and if my whole femoral vein was socked in and there was no flow, with these pure thrombectomy devices, I think the risk of the procedure certainly isn't nil, but it's very low. I might have one of my partners take it out. If I was really socked in from the proximal femoral all the way through the popliteal. Because again, it's a little bit of a roll of the dice. Is Elias for 3 months really going to resolve it?
Yeah.
And once it gets old and organized, it doesn't respond well to much therapy. So I might let one of my partners do it if I'm really socked in with just a femoral popliteal DVT.
Would you let Tom or Makis or John also do it to you?
Absolutely. That's why they're on the podcast. But I wouldn't want a thrombolytic. Yeah,
no, and we're going to keep all these thoughts because we're going to get into that in the next question or two. Tom, give me another gray area, if there is any that you can think of.
Oh, absolutely. Yeah. I mean, anything, for me, anything below the inguinal ligament, femoral on or off limits. I mean, if it extends down into the so-called superficial femoral in the thigh, I think that the results just aren't what you want. Everything else for me is a go. Any iliofemorals, cables, obviously.
So, Makis?
To make things a little more gray.
Go ahead. My hair is as gray as it can be, and whatever hair Mitch has is also gray. So go ahead.
We are talking about jumping on an intervention, but I can challenge you, telling you, if you sit on anticoagulation with the femoral popliteal DVT for 48 hours and your swelling has gone down and you walk around without a problem, would you still want this thrombectomy procedure?
Go for a bike ride.
A very good chance that your symptoms will go completely away if you do anticoagulation within 48 hours.
Right. And, there's a lot of practitioners that practice just that way. They put patients on full dose Lovenox for 7 to 10 days, see them back in the office. If they're still symptomatic, then it may be more appropriate to do it. I think that's not a bad option. And patients that we're on the fence with, we sometimes put on just Lovenox, see them a week, 10 days later. If they're still symptomatic, go in and do it. And Steve will get into the devices, but some of these devices do pretty well with more, the classic teaching is 14 days or greater, things don't respond well, but I don't think that's the case anymore.
Yeah. So John, is your practice someone, not a phlegmasia patient, but someone who has some swelling, some pain, and everything? They have a iliofemoral DVT, and they're that questionable. They're a little bit older. They have some comorbidities. You're a little concerned. Do you give them a trial of anticoagulation first and then see them back?
We do. And it's changed over the last while. So it used to be that that's the sort of patient who probably would have been admitted to our hospital. And then we may or may not have done a procedure during that admission. But now they are all kicked out of the ER. And so they're the people who come back to our office. They get an appointment for 5 to 7 days. And if they are symptomatic still on their DOAC at that stage, then we'll have the talk with them and about an intervention. But there is that percentage of people who either don't show up or are symptomatically great. And I think it's a bit of a learning thing for us that there are some of those who definitely 5-10 years ago would have had an intervention and ended up in the same spot as they were with just the anticoagulation.
Yeah, I don't think in general it would be wrong to watch somebody for a couple of days on I prefer Lovenox because it's acute and there's an inflammatory thing, and then bring them back just like Mitch, you guys do and stuff, and see how they do. But I want to use the analogy of most of you were not around when we changed from open gallbladder surgery to laparoscopic gallbladder surgery, but and probably most of you didn't do general surgery training. Tom probably did, and Makis. Did you do general surgery training, Makis? Yes, I did. Okay. My point is, all of a sudden, when the procedure became less morbid to the patient, there were many, many more people that were undergoing cholecystectomy from the laparoscopic viewpoint. So I want to get into a little bit of the technologies that we have. And because these technologies, Mitch, as you already alluded to, are more benign now than perhaps they were when we were doing, intravenous TPA or urokinase or whatever, does that change our indication? So talk a little bit about, Makis, why don't you give us a little talk about some of the technologies, maybe the Penumbra device, how that works?
The Penumbra device, I personally started using it around 2016. This came out of the stroke world, and when the Cat 8 came out, that was a relatively big device and appropriate for venous. And I started using it in both DVT and PE. We actually later took it also to the peripheral arteries. But as far as the DVT, particularly when you're treating a clot that's relatively fresh, Penumbra Cat 8 could actually work without any lytics. But even if you had like a subacute clot, you could actually do pharmacomechanical thrombolysis the way we are used to use it with angiojet. This turbo pulse technique, inject some TPA, and I'm not against TPA. I actually like some TPA for the patient who's not contraindicated. So Penumbra Cat 8 with some TPA on occasion would actually work very well. Just an 8 French sheath, torqueable device, easy trackable device. It's not very bulky and can navigate around without difficulty. And now, I'm sad because I haven't yet used it, the Cat
10.
And I'm looking forward to it. I anticipate like a lot better results, bigger chunks of clot removed. But I'm still waiting to use it.
So that's a non-thrombolytic device. I mean, you can use thrombolytic with it, but in general, you don't have to. Mitch, you want to give us another thrombolytic device, your experience with the ClotTriever? I know you have experience also with FlowTriever with PE, but let's talk about ClotTriever for not PE, but for IVC and iliacs, et cetera.
Yeah, no, thanks. We've got a very busy VTE program, so we've tried all the devices. We really have. And ClotTriever for iliofemoral DVT has really revolutionized our practice. It's a pure thrombectomy option. It's very rare that we have to give any adjunctive thrombolytics. And the first impression is, well, that's great. Bleeding complications are going to be less. But what it also means is it increases your therapeutic window for patients that have contraindications to thrombolytics, patients that are post-op brain surgery, spine surgery, that before you had no option for venous intervention. But it also translates into that, single session result. Patients go home the next day. Their length of stay is shorter. The hospital system loves it because of the economics. So for us, ClotTriever, because it really is a pure mechanical thrombectomy, I can count on one hand the time we've had to give adjunctive lytics. We get the on-the-table result, and it's been very good. It's been very good.
Yeah, no, we've had a good experience as well. John, now let's move into the thrombolytic options. You've had experience with what do you call it, with thrombolytics and stuff.
Yeah. So, as we were talking about earlier on with ATTRACT, the bulk of the evidence for what we do comes about from catheter-directed thrombolysis. So if you have something that kind of builds on that evidence and makes it into more of a single session treatment, then that has a certain cachet and hook to it. And what the Thrombolytics company have done is they've come out with a line of catheters, the Bashir line, which have a basket that expands up on one end. And the idea being that it kind of macerates the thrombus, disperses TPA deep into it. So, you uncover these fibrinogen binding sites that previously the TPA wouldn't have gotten into. And then it also has a multi-side hole catheter down the shaft so that you can treat long segments as well. And so we've had pretty good experience over the last short while, maybe about 6 months or so with it. And I think it has a role. I think it's been definitely better than what we had before. And I think that increasingly what we see, to Mitch's point, is that there's a large volume of patients who need this sort of treatment, and that one device is very good for one portion of that population, and that perhaps this will be good for a different portion of the population, maybe the younger people who TPA may be a very good option for. So I think it's going to be interesting to see where it fits in with the armamentarium of all the devices over the next while.
Yeah, and I agree with you. It has the ability to infuse, make multiple channels and infuse, throughout the thrombus rather than just a central channel as well. So, the theme of this podcast is respect the elders, embrace the new, and encourage the improbable and impractical. So, Tom, tell us a little bit about the elder statesman here, which is the AngioVac, the AngioJet device and ECOS a little bit.
So, look, AngioJet's one of the oldest out there, right? And the nice thing about the AngioJet has always been it can be standalone therapy. It was standalone therapy. Works by Bernoulli principle, shoots saline out, sucks it in, creates a vacuum, immortalates it, takes it out of the body. The catheters have evolved tremendously since then, and now there's the Zolante, which is the 8 French catheter, which is a lot more powerful. We've been asking for that since day one, because anytime you got into the IVC with the 5 French catheters, it took forever. The downside, and I've noticed it several times. I've had several cases. That is, there's a renal issue potentially, and that's the scare. So even if you're not thrombolysing, you're still getting systemics no matter what, and you're lysing cells. And I think that burden on the renals, if you're not hydrated, can be quite detrimental. So I've had 2 people go into frank renal failure with full reversal, young people. I don't know if it was some kind of crazy allergic reaction, but you do have to be careful, particularly with these new catheters, and if you're in the IVC and around the renals. But it can be standalone, and the nice thing is pulse spray. We used to do it with clamping the outflow. I'm sure, whoever's been around long enough did that. And then, that kind of evolved to give us the pulse spray functions on the machine. So it's a great all-around device.
Yeah, no, and many times we use it kind of as maybe not first line, but kind of as a cleanup if there's anything left over. So let me, Mitch, you look like you want to say something.
No, I'm enjoying the discussion. Go ahead. I do want to make a point, but go ahead, Steve.
No, I'm going to change a little bit. So if you want to make a point on this, make it.
The thing that the ClotTriever and FlowTriever has taught me, and you as a surgeon, you probably have known this, is the clot that we pull out, we actually get to look at it and play with it and touch it. It's very heterogeneous. Some of it is bright red and very soft like Jell-O. Some of it is white and it's like rubber. It's like calamari. And I think in part, the patients often have more sort of subacute presentations, and the clot could be instead of very fibrin-rich in an acute clot, it's very collagen-rich. And that's why thrombolytics sometimes don't work that way. And again, that's why I've been really pushing towards this device that no lytic, pure thrombectomy, and it's aggressive enough that it pulls, the wall adherent more chronic clot off the iliac vein very nicely. And it's taught us a ton. And as a cardiologist, I never got to see clot like that. It's really impressive how heterogeneous the clot is.
Yeah, no, we see that but I just want people to understand, even though it's called the clot triever, clot only occurs in a test tube. Thrombus occurs in the body. So they should have called it the thrombus triever or whatever the hell they're going to call it. But we all get the idea. We all call it clot. And because obviously we call it deep venous thrombosis. We don't call it deep venous clotosis. So it is it's a thrombus that we have. So let me challenge you guys. Why should the algorithm not be for anyone with acute venous thrombosis? Why should the algorithm not be, except if it's a leg-threatening, problem? Why should it not be anticoagulation for a few days, see how the patient does? They're not doing well. The next thing you do is a non-thrombolytic device. And if you can't get the thrombus out of that, you then go to a thrombolytic device. Is there any reason that algorithm should be different? Or is this just somebody jump in?
I mean, I think that sounds like a very reasonable algorithm, but still, there are some exceptions. For the patients who have extensive iliocaval DVT, how many times do you think you can be successful with a single session thrombectomy? Even the clot triever, even the penumbra, because I like all devices. Mm-hmm. The clot triever can not get the entire lumen of the vena cava. Many times we have patients who have IVC filters. Again, these devices do not work great through IVC filters. So lytics for the appropriate patients still have a role for a few hours. But overall, I think the algorithm you are suggesting is a good start.
John?
I agree completely. I think it's a really good start. I think there are going to be people who are going to start asking about the cost of this. But, as someone who kind of believes in the technologies we have and in the results that we've seen in the patients that we've treated, I think it's worthwhile in almost all cases.
Tom, what do you think?
I think we're leaning in that direction. We talk about in conference often. I think that's very, very reasonable. I do think that the ultimate is going to be a combination therapy. I don't think that one is alone always is going to be enough. And I think a cleanup agent of some sort usually helps, because the vessels, no matter how good they look, or they definitely have some fibrin attached, and that's thrombogenic. So if you can clean it up, I think that's going to be, the answer in the long run.
Mitch?
Steve, I'm going to be a little more aggressive and say that in the iliofemoral population, when we do intravascular ultrasound, probably about 2/3 of patients have some anatomic issue in addition to the thrombus. And that's why, 40-50% have post-thrombotic syndrome with just anticoagulation, because you haven't dealt with the outflow issue. So the iliofemorals, if they have a good functional capacity, they're not 90 years old. Maybe we even do 90-year-olds. I shouldn't say that. But the point is, we investigate the majority of them. And part of that investigation is intravascular ultrasound. And, about 2/3 of patients, we see significant iliac vein compression, and we fix it. We need to have more prospective studies on that approach. The more aggressive approach. We need to redo the ATTRACT trial with sort of 20/20 venous intervention and see. So our center leads to being probably a little more aggressive with iliofemorals.
Yeah, and I do think, and that actually was my next question. Should anybody be doing this and not be using an IVUS before they say we're done?
In my opinion, no. If you're going to do venous intervention, and it's an iliofemoral DVT, you have to do intravascular ultrasound. Venography, and we know that, Raju's published that a few times, underestimates disease. You look at the video trial. It changed the therapy in 50% of patients.
Yes. Makis?
Well, to challenge this a little bit for the sake of the discussion, actually from UCLA, Joint of Vascular Surgeons published it, and another publication from Anil Hingorani in New York, they believe that 2/3 of patients you can get away without IVUS. Just because it is obvious there is a lesion, you stent it. If you follow a liberal stenting algorithm, you can get away most of the time. I'm personally an IVUS user, but there are many people out there still not convinced, and they have good outcomes. If you keep placing the stent, no matter what, you may not need the IVUS.
Yeah, Tom?
Steve and I have had these conversations forever. And look, I just happen to be old school. I'm turning the corner with IVUS. We use it. I think when it's necessary. I do not use it on all of my cases. I kind of go with just my, experience, with my experience over time. We've had good results. We're real aggressive. And, I think that's probably the future, but I do not use it on all my cases.
So the two last things I want to talk about. Are we still missing a lot of patients because we have the DOACs and because ER physicians and primary care physicians don't feel this is a life or leg threatening problem, and these people just anticoagulation, nobody follows them, and then we see them a couple of years later. Are we still at that point? Anybody?
100%. I'll tell you, Steve, how I think I know this is because so many of them are finding us through Facebook groups and patient portals and disability groups and everything like that. So these are people who are not coming to us from the conventional kind of referral patterns, but rather searching out treatment themselves because they feel that they're being left behind a bit.
Right.
Yeah, and I don't think the primary care physicians, the internists, the hospitalists, or the emergency room doctors care whether there's data or not. I think they just feel it's relatively easy to give them a pill and go home. And it's a shame. There's so many people, because we have so many more devices, which we have just elucidated, that can safely take care of these people. And I honestly think that, as I asked you, Mitch, if you had your, femoral popliteal DVT, I honestly think the safer these things become and the simpler they are, more people should probably wind up having their thrombus removed rather than less people, honestly.
Steve, I agree. I think it's a shame in the year 2020 that care is still so fragmented, hospital to hospital. I mean, sometimes they don't even think about the diagnosis of DVT, but then they get the duplex that's an iliofemoral DVT, and they don't get a consult. They don't get the doc involved that really understands the disease. Sometimes they get a vascular doc, and they don't do the right thing, and I think DVT is something that could be very much put into a care pathway. 90% of the time we can probably do the same thing. Care is very fragmented. And John, you're right. We see a lot of people months to years later that have chronically swollen legs, and that window of opportunity was lost because they got undertreated. So all right, let's get down to the end here. So what are we missing? I actually have a couple of things I think we're missing, but I want to get your guys' thoughts first. What are we missing in the management of acute venous thrombosis? Anything, or we have everything? I'm not even talking about devices. I'm talking about a thinking process. I'm talking about a diagnostic process. Is there anything we're missing that we would want that we could make the care of these patients better? And if you guys don't have it,
from your last comment, we are missing awareness and the education of the public and the community physicians, so that there is an appropriate referral pattern to the large institutions where appropriate expertise exists for the better care of these patients.
Right.
All right. So I'm going to throw some things out because you guys didn't have time to think about this. I did before this podcast. How about, would it be good if we had better criteria to determine the age of the thrombus? Would that be helpful to us in managing these people?
It would be helpful, but I don't think it's solving the problem that Makis was talking about, is just awareness, right? People making the diagnosis, and then when the anatomy is such, iliofemoral, high risk, getting it to the right doctor. The care is still too fragmented. I'm sure, I think that would be helpful if we could use MRI or what have you to really date the thrombus, but I don't know at the end of the day how much it's going to really help, to be honest. My last comment about a track, though, the unintended consequence was the primary care base looked at that as a negative study. Yeah. And we did see a drop in referrals, and my friends across the country did also. So we got to educate them that, the technology post-attract is much better.
Right. So John, what should be our endpoints when, not even if we're doing a trial, what is our endpoint when we're treating a patient? What are we going to say, hey, we did a good job here, we helped the patient? What do you think the endpoint should be?
I think you're talking two main things, right? There's the technical endpoint. And on the technical endpoint, you really got to get almost all the clot out. And when I say almost all, you want to get 99 to 100%, because there's nothing more thrombogenic and cholinogenic within the vessel than residual clot. So whatever we're using, we want to get a really, really good result with it. And then from the patient's point of view, they don't really care about that. What they care about is their quality of life. In other words, you want to have a good metric for their leg pain, swelling, and walking metrics.
Yeah. I mean, to me, that's, yes, we need to remove the thrombus. A lot of studies have shown the more residual thrombus, the less the patients don't do as well, and they have a higher rate of rethrombosis. But I think the quality of life is really the main thing. And the best thing we have is a Villalta score, but it's not the best, really. We're all saying that, and we're all like, okay. But in every single paper, the Villalta score is quoted that it got better in all these people. But yeah, the quality of life is really the key. Fast forward 10 years from now. What would be the best thing? What would be your, like, the world of Oz, the land of Oz in the management of venous thrombosis? What do you want to see? Someone hits the ER, iliofemoral DVT, swelling, pain, not a threatened limb. What would you say? What is your, like, fairy tale ending?
Well, obviously a non-invasive external something, whether it's ultrasound based, that will break up the clot without any kind of invasive intervention and put all of us out of business, which would be good for patients, but bad for us.
Well, okay. You're being very altruistic. I don't know if I'd be that altruistic, but 10 years from now, I may not be practicing, so that's okay with me. John, you are the Wizard of Oz, John.
Yeah.
You are going to make everybody happy. What do you want to see?
I think I'd want two things. The first is, before this happens, I want someone really famous to get this and get it bad. And I want to see a lot of publicity about how bad it is and how great they would have done if they'd have got seen and treated early. And then when 10 years from now, the people who know this person come in to see us, I want a device that is low profile. So ideally one that's easy to put through the popliteal, that is a mixture, I think, of removing the thrombus directly by whatever mechanism that is, and dissolving any residual thrombus. And potentially one that also resculpts the vessel so that our stent numbers are perhaps not as high as they need to be right now.
Very interesting.
You probably have them 2 years, not 10.
Makis, and Mitch, you're the last guy, so start thinking.
Follow John's thoughts. I want this small profile device that gets in through a tibial vein around the ankle. It has a IVUS eye. It can thrombectomize, and it can also throw lytics through.
Yep. Mitch?
About that.
I like that.
Steve, we always have room for improvement. I think device size right now is on the large size. ClotTriever's 13 or 16 French in the popliteal, but we're almost, in our practice, we're almost at nirvana. We have a pure thrombectomy device. We IVUS. I'm telling you, most of the clot is gone. If there's compression, we put a dedicated venous stent, give them Lovenox on the table, they go upstairs, and uniformly they go home the next day. So compared to what we were doing 15, 20 years ago, we've landed. We're in a good place now. The device sizes could be smaller.
All right. But I kind of like Tom's idea too. If we can do it all from the outside and put us out of business, that's the only negative part of it. But I agree with you. I think we've shown there's a lot of really good options that have occurred in the last couple of years. And I do think if we get a little better data, we're going to be a little more liberal than we are now in getting out this thrombus with people, because we do have young active people who develop it, and even older active people, as well as all the routine stuff. I want to thank you guys. Great discussion, and we will see what happens. Whose predictions come true? So thank you all.
Thank you very much.
Thanks for having us. Thanks. Good night, everybody.
Good job. Really good job. We hope you enjoyed today's Vein podcast in association with Radcliffe Vascular. We aim to bring you important topics from the vein world, either topics that we ourselves feel are important or you, our listeners, feel are important. So review us on your favorite podcast app or send your thoughts, comments, and questions to podcast@radcliffe-group.com. That's podcast@radcliffe-group.com. You could also register to access newsletters, videos, and peer-reviewed journal articles. Thank you. Glad you listened. This is Dr. Steve Elias, and we'll see you on the next Vein podcast.